The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. We are getting our presenters on, and we will begin in just a few minutes.
I just want to thank you all for your patience. We've had some technical difficulties with one of our presenters, but he is working to get back on. I will go ahead and do my introduction. I want to welcome you all to Levels of Care. Are you ready to launch your Levels of Care? And good afternoon or good morning, depending where you are in the country today. Thank you for joining us. My name is Annie Jensen. I'm a licensed clinical social worker and senior trainer of the DLE 20. I have been with MTM Services for about 13 years now, with my primary role working around the DLE 20 outcome work and integrated healthcare work. And before that, spent about an additional 15 years in the behavioral health sector in a variety of leadership roles. So I'm very excited to be with you today and get ready to do our presentation. We are going to hold tight for just a minute for David Swann to join us. Okay, I think we're going to go ahead and get started while David is still working on this. Jody, if you could expand the screen. And if you could go ahead and start the slides, we'll move down and we'll start with my part of the presentation. And if you could go ahead and keep going, we'll save those so that David certainly has the luxury of getting to present to everybody also. And we'll start, Jody, right after the first poll question. All right, so we're going to go ahead and get started, and I apologize again for the technical difficulties. I know that David Swann will be joining us as quickly as he can. So we're really talking about two things through this presentation. We're talking about setting the stage for the importance around measurement-based care and level of care work. And where I want to start with you all is talking for a minute around basically, let's just get a little bit of a foundation about measurement-based care. So measurement-based care is really the practice of describing and using a systematic and routine assessment to measure a patient's progress over time. And it really is about almost an evidence-based practice that you're using to measure the progress, the outcomes, inform treatment decisions, and continue to engage that individual in treatment. One of the critical issues in behavioral health care is having those accurate indicators that measure the impact of illness on people's day-to-day functioning. That's one of our challenges. How do we show that an individual, that their symptoms and or their diagnosis is actually impacting their functioning on a regular basis? So what you're looking at on the screen right now is, in the past, what did we use? The GAS was kind of our standard measure when we were trying to define the level of severity for an individual. But when the DSM-5 came along and the GAF went away, that's when we all started to look for some of these different indicators that we could use. So what you're looking at on the screen is you're looking at a crosswalk. With this crosswalk, you're looking at the DLE-20 being our primary indicator tool. So the DLE-20 stands for daily living activities. The DLE-20 is a functional scale that takes all of the symptoms and all of the diagnoses, and it looks at how does that impact the individual in these 20 quality of life indicators. At the same time, we know there are a lot of other options of different indicators and tools that can be used. So one of them you're seeing on the screen is the ICD-10, where we basically come in, we give a 4th-digit modifier. That 4th-digit modifier specifies the severity for the individual. The lower the score, the less severe. You can also see on the screen that we have the HUDAS. The HUDAS is the World Health Organization Disability Assessment Schedule. You all know that is another self-report measure that looks at symptoms, it looks at functioning, and it looks at level of distress. You can also see on there we have the locus, which is another level of care tool. And you can see that we also have crosswalk the DSM-5 count of symptoms. One of the things also, let me go back for a second and acknowledge also, there are a lot of other symptom checklists that individuals use too. The PHQ-9, the GAD-7, our list is pretty endless within that area. But when you start to think about bringing all these tools together, integrating them into a crosswalk to be able to specify and identify the severity for an individual, one of the things you're going to notice when you're looking at this screen is that you're looking at with the ICD-10, with the HUDAS, and with the PHQ-9, the scoring is flipped. And so a lower score actually reflects better functioning or less symptoms. However, on the DLE-20, the DLE-20 really challenges that idea that, in quotes, no problem is the best status. Is no problem really a recovery outcome? And I think that's really the question. So what the DLE-20 does is actually looks at it to say, the higher the score, the greater the strength for the individual until you reach a 7 in each area. And when you reach that 7, we're able to identify that area. Instead of saying no problems, we're able to define what is the skill and what is the individual doing with optimal independent functioning. So this is an example of a crosswalk where because what we're going to start to look at is an example of a level of care. When you look at a level of care, you have to be able to define what's going in as your actual measurement that you're using, your indicator. So this is an example of, you can see we took the DLE-20. Let's look at our 5.1 to 6 area. So that's a very high score on a DLE-20. That's demonstrating mild impairment. And then you can see we crosswalk that to the ICD-10, to the DSM-5, to the HUDAS, and to the locus. Again, representing that for those tools, the lower score means the individual is functioning better. For the DLE-20, the higher score indicates that the individual is functioning better. Versus just defining no problem, we're actually defining the strength that they're demonstrating. Next slide. So here's one more example for you. The last example I showed you was actually a strength for the individual. This is now an example of an individual that is starting to experience moderate impairments in functioning based on their DLE-20 score. So now as we start to look at this, our ICD-10 modifier is increasing. Our DSM-5 count of symptoms is increasing. Our HUDAS score is increasing. Now we have kind of a locus score put in there and an ASAM score put in there. So now here's an example as our DLE-20 score decreases, Our other scores are improving for the individual. Okay, next slide. So let's talk for a minute around what is this level of care? What is a level of care? What goes into a level of care? And what are your critical components? So when you take a look at this actual level of care on the screen, one of the first things that you see with this is the critical component is what is going to be the indicators of your level. So I just took you through some crosswalks where you could see that there's, and that is by no means an all-inclusive list, but an example of some of the different tools that are potentially used. So when you're selecting your indicator of the level, what we have to be able to do is we have to be able to select a tool that we're going to be using or multiple indicators that we can crosswalk together, just like that you saw. So this sample level of care uses a qualifying diagnosis, and it also uses a DLE-20. And I think, you know, as you're thinking about selecting your indicators for the level, something that becomes so important through this process is selecting a tool which really captures the significant variation across and within diagnoses for both physical health and mental health. It's going to allow you to more accurately place an individual in the correct level of care. And the reason I say that is if you think about you have two individuals with depression or two individuals with trauma, they can be impacted very differently in their quality of life indicators with their diagnosis. And just placing an individual in a level of care based on their diagnosis does not really provide that individualized person-centered care. But instead, when we take an individual and we say, I'm going to look specifically at how your diagnosis and your symptoms from both a physical health perspective and a mental health perspective are impacting your functioning and quality of life on a daily basis, that's when we're going to be able to get individuals into an accurate level of care, kind of based on their current functioning versus just a diagnostic category. You can also see then the other things that go into this level of care. You can see that we define the typical length in service. So this is an individual in the 4.5 range of a DLE-20, which is moderate impairments. They're not serious or severe yet. So your typical length of service you can see is up to a year, but we want to continuously reassess. We want to make sure that what we're doing is working. We want to make sure that the individual is improving and getting better. So this is a continuous reassessment while the individual's in our level of care. You can see that in this level of care, some of the services that they could receive is obviously everybody will start with that diagnosis and assessment, and we define up to 2 contacts. Crisis intervention, we will not limit, so it'll be as medically necessary as the individual needs to use that service with us. Counseling and therapy, you can see this is defined up to individual sessions, 8 per 90 days, and or family therapy if needed, 8 per 90 days, and or group. And group typically sometimes tends to stay more unlimited as needed, because with your groups, you might be following an evidence-based practice where it's determined how many sessions. Also, they might be starting to participate in more psychosocial rehabilitation. And we know that those are extremely beneficial when we start to look at some of our quality life indicators around feeling connected. Under medication services, 2 to 3 contacts per 90 days, there will certainly be exceptions for that. If there are medication protocols, black box warnings for when an individual is starting a medication, the prescriber will be following that. And then lastly, you can see community support services. So building this out based on services you offer, targeted case management, community psychiatric rehabilitation, psychosocial groups, peer support groups, and defining kind of the amount of that around 10 hours per week of eligible services. So the first message I want you to hear from me is this is a menu of services. A menu of services saying not each person will need all of these services at the same frequency, intensity, and duration that is on this document. Again, what we're doing with this is we are tailoring it to provide individualized care, but within a framework of this level of care. You can see down below the possible descriptors of an individual in this level of care. There is no imminent danger at this level. There's moderate structure in their life. You can see we list some of the areas they might be experiencing impairments. And then over on the right side, you see your transition and your discharge criteria. Notice it says transition or discharge. This could be an individual that's actually going to transition to even a lesser level of care before we successfully discharge them. Or this could be an individual at this level that says, I've met my goals, I'm ready. I'm ready now to be out on my own and be able to do these things on my own successfully again. So there's a lot of flexibility how these individuals move through the levels of care, and when in our person-centered approach, we determine as a team, the consumer and the treatment team, that they're ready for discharge. Some of those criteria: stable on meds, they can self-administer them, they have the supports in the community they need, their medical needs are addressed, etc. So again, this is something where you all will have access to the presentation, and also in the presentation will be the screenshot for you to look at in more detail if you want to. Next slide. So let's talk about this. We just talked about a framework for a level of care, but now how do we use this level of care? How does this level of care truly benefit us at each level of the organization? And so the first place that we can start to talk about how we use our level of care is in open access. And I'm going to say the first thing that is so critically important when an individual is coming into services is consistency. That whether an individual walks in door A and sees clinician A, or door B and sees clinician B, do they get the correct services? Did we arrive at an accurate assessment with consistency and inter-rater reliability to where we identify the same needs for the individual? So again, that goes back to, in your level of care, what tool are you using? What is your measurement-based care tool that you're using that is your indicator for the level? Because that tool should generate consistency across the providers that are bringing individuals in. So it ensures the consumer is going to receive the correct services at the correct frequency, intensity, and duration, because we're going to place them in a level of care. Again, remembering that that level of care is our framework and our menu to services. Discharge planning starts at the intake. From the moment an individual comes through the door, we are not buying them a lifetime of services. We are talking about our discharge planning from the moment somebody comes in. People want to know there's hope. People want to know they're going to get better. And that doesn't feel very good if we can't help them put this in a framework of about how long they're going to be with us. Caseloads can be balanced based on acuity. If I keep giving the same provider individuals that fall into a level of care, a very high level of care where they need a lot of services, and they're experiencing extremely severe impairments, we don't have very balanced caseloads. And we know what happens then to our staff: burnout, they're tired. And so how do we balance this so that caseloads are equally distributed? Well, when we have levels of care, we're able to do that more effectively. The other thing that the level of care does in our open access is it establishes a commitment in a treatment partnership through transparency. Next slide. And the reason it does that is this. This is why we get the transparency. This is an example of actually providing the treatment team and the consumer a copy of their level. This is not a secret. Our goal through this process is to be transparent from the moment they come through of, based on how you're currently functioning, let's talk about the services that you feel would be beneficial. Let's talk about what your level of care shows. And let's talk about what you can expect from the frequency, intensity, and duration, and how long you're going to be with us. And that we will certainly ensure that if things change for you, we do a reassessment with you. We want them to understand that. We are a partner with them walking through this process. Give this to them. Give this to the treatment team. They know then what their care looks like. We've defined their care. David and I talk a lot about, we're really good at this with physical health care. We're not as good at this with mental health care. With physical health care, if I go in and I have a diagnosis, they're going to lay out a care plan for me. I'm going to know when I'm going to see them next. I know what I need to take. I know the next test I'm going to receive. If I'm going into ongoing treatment for something, I know what that treatment frequency, intensity, and duration looks like because I have to be there. We need to be doing that the same way in behavioral health services. So this is actually another level of care for you all to look at. This one looks a little bit different than the one I just showed you in that this is going to be an extremely brief level of care. This is an individual functioning within normal limits. So this is a person where we've hit just a brief impact in our functioning based on a life event. So we're going to do a very targeted approach to where the functioning has been impacted with the goal of hoping to get them on their feet and on their own again very quickly. Next slide. Let's talk about how we use levels of care and supervision. So when we use levels of care and supervision, a couple things around this. Our goal in supervision is to be proactive. It is not to be reactive. Everything on this slide lends itself towards being proactive in supervision. So when we're using levels of care and supervision and we're meeting with the staff, how are they doing implementing and evaluating the effectiveness of the evidence-based practices they're using within that level of care? One of the great things about using levels of care is we can start to define out what are the typical evidence-based practices that can be used within that level of care based on the severity. Now, there's going to be a wide range because not everybody's going to be receiving the same evidence-based practice, but is it working? And is the consumer responding? We're going to know that by, again, like I talked about in the beginning, doing those systematic measurements over time and ensuring that the individual's making progress through that level of care. So how do we define that progress? 4 things for you. Positive change, meaning it's achieved and we want to remove it from the treatment plan. Positive change, but we're not quite ready to remove it. We want to continue our current interventions to improve their functioning a little bit further. So we're seeing the change we want to see, but we're not quite there yet. And we want to ensure further stability. Or are we starting to see partial response, no response, or decline in functioning? And I kind of call that our stuckness factor. If we're stuck and we keep putting on a treatment plan the same goal, and we just keep putting continue, and 9 months later, we still got continue, but we haven't made any progress, we're stuck. So how do we reevaluate that goal and intervention to determine what changes are necessary based on our data? We're really moving into a time of data-driven clinical decision-making at the individual level. Caseload management, again, severity. Are you supervising someone where we tend to give them all the hard consumers because they're really good at that? So how do we look at their caseloads based on the different levels of care of the individuals they're currently serving? And the next thing, how we know that not everybody that goes into a level of care is going to fit within that framework perfectly. This is still about individualized, patient-centered care. So what do we do if we have an individual that doesn't fit perfectly, that maybe isn't responding at the same pace as other individuals, but we're still seeing the response we want to see? What do we do for that? Go ahead, next slide. So here's an example of an exception form. Here's an example of where we're going to have that clinician work through a case conceptualization process. What we want them to do is really think about it from the perspective of what are they receiving? What are their current goals? What's their response to treatment? What's their level of participation? What are their current support systems? And why do we need additional services? If what we're doing is working, why do we need additional time or additional frequency, intensity, or duration of services? And if we can answer those questions, and if this is really more the exception versus a rule, right? Our consumers should be able to fit within these frameworks most of the time, but you're going to have exceptions. And if we can successfully answer these, and if we feel like this is what they need, this is a great tool for a supervisor and a staff member to use to say, let's step back, let's conceptualize this case, let's see what's going well, let's see what's not going well. At the same time, let's make sure they're engaged, let's make sure they're buying in. And this isn't a situation of we need more sessions, but we're stuck, or we have half the participation we need. Next slide. And then level of care uses for leadership. It allows, when we think about it from a leadership perspective, looking at the acuity and trends of the population we serve. So one, do we have a nice bell curve of the individuals that we serve around? We're going to expect kind of a peak in that middle range, and then we're going to have individuals that are also more severe and less severe. It also makes sure that your bell curve isn't skewed significantly one way or the other. And when we talk about if their needs are being met, are our current practices and programs, or evidence-based practices and programs, working for the individual? It allows you to manage community needs versus capacity. And what I'd say about this one is this: anybody can fling a front door open, but how do we manage our back door? We have to be able to meet our community needs. To be able to do that, we have to have movement through our system. Levels of care create movement through the system all the way to discharge. Also, it allows leadership to have a greater knowledge of the cost with each level of care. You can cost out your different levels. I know if an individual's in level 3, this is how much they're going to cost, because this is how much 20 hours of community support costs. This is how much our therapy costs with one session a week. This is how much our assessment costs. And it also helps to prepare you for those integrated service arrangements with the broader healthcare home system. Because again, what are we able to show? We're able to show our value. We're able to show that we can get people in. We can meet the community demand and needs. It's not that we're going to partner with you, but we can't see anybody. And we have a good sense that what we're doing is working. Next slide. So let's talk for a minute around the barriers to measurement-based care and level of care implementation. This is critically important. If we're going to be successful implementing a measurement-based care tool, if we're going to be successful putting our levels of care in place, what we need to be able to do is address those barriers head on. So this is from the American Psychological Association around, they identified 3 levels of barriers: the patient level, the provider level, and the organizational level. Next slide. So the patient level, what are some of the typical barriers we hear? A perceived burden of too much paperwork when somebody comes in. Too many questions being asked. You asked me the same questions already. Now you're asking them of me again. That it's not relevant to treatment. Do we just give them a self-report tool that we never talk about again? And we give it to them once a year because we've got to meet a requirement? Or do we truly take our measurement-based care tool and our levels of care and apply it to their treatment? And for our patients, the fear of what do these results mean? Will I look too good? Will I lose the services I have? What does this mean for my treatment? Next slide. The provider level. When we talk about the provider level, what are some of the concerns? They're concerned with resources. Do I have the time to do this on regular intervals of measuring progress over time? Is it a billable activity? How does it impact my caseload size? You just added 10 minutes to my assessment, 15 minutes to my assessment, 10 minutes to a reevaluation on a regular basis. A lack of understanding of measurement-based care and levels of care and the importance in the treatment process. Concerned with how the data might be used beyond treatment decisions. So a provider thinking about it from the perspective of, how will I be looked at? What does this mean for me? What if some of my consumers aren't doing well? Will this be reflected on my evaluation? And lastly, and something we hear all the time, change fatigue and overload. One more thing to do or one more change if we're changing tools. Next slide. And at the organizational level, lack of an electronic health record or an automatic feedback system. Data in's great. Data in means nothing if we can't get data out. Increased administrative time burden. If we don't have a good system and now we have to use manpower to enter everything, that's going to be a huge burden on our system. The financial costs associated with either purchasing a tool in your electronic health record or purchasing an electronic health record or purchasing the measurement-based care tool. Turnover of staff, because when there's turnover of staff, that means we're doing more and more training on our tool. We have to make sure people have the support and the training on the tool that we're using and the levels of care we're using. If staff is turning over at a rate of 50%, we're doing a lot of trainings. And really the lack of support at the leadership level. Is the whole leadership team on board to be able to support the organization through this transition? Next slide. So your poll question. So I'd like you all to take a poll for me really quick, and that is, what level has the most barriers for your organization as it relates to successful implementation of measurement-based care and levels of care? Is it the patient level, the provider level, or the organizational level? I'll give you about a minute to complete that. Okay, Jody, we're ready to close that. And so here's what we see. At the patient level, 21%. At the provider level, 44%. At the organizational level, 35%. Thank you for participating in that. You see a pretty consistent distribution across the different areas, with the patient level certainly being the lowest of those. Next slide. So what do we do about that? Here's what we have to do about that. The first thing is, you all just identified the level with the most barriers. We needed to do that. We needed to identify it. What's your next steps? We need to remove any barriers we can remove, or minimize any barriers that we cannot remove, so that we can certainly successfully implement measurement-based care and levels of care. We need to be able to clarify roles of staff. What do staff care about? How does this impact me? What is my role in this? And if we're like, we don't know yet, we'll figure this out, that doesn't go very well with staff. We need to make sure staff understand their role. We need to assess and address training needs to make sure they have the core competencies and expertise. When staff feel confident in what they're doing, there's going to be, one, more buy-in, but two, we're going to see a much higher level of inter-rater reliability. So how do we provide not only the initial training, but that ongoing coaching and being the super users for our staff when they have questions? Providing frequent and honest communication with staff. Why are we doing this? How is this going to be beneficial? How does this help the treatment we deliver? How does this benefit you? How does this benefit the consumer, the organization? And having opportunities for them to talk about it. How are things going? What is your biggest challenge now that it's implemented? In order to do this, all staff have to demonstrate competency and fluency in your measurement-based care and your levels of care. You're moving into a cultural shift within your organization. So with that, I want to thank you all. And at this point now, you get to hear from the real expert, David Swann, who is on with us. And so I want to turn it over to David and make sure he has time because he has a lot of great information for you.
Yeah, thank you, Andy. And I felt like that first poll question that you used was very, very informative about the amount of barriers that are greater for providers and for organization than they are for the consumers. That's very consistent with what we hear across the nation, and so that's very much helpful. And what I want to do is try to cast some advantages for you. This is the context of kind of what we're dealing with. First and foremost, the whole reason why that we might do this is because of something that we have heard a lot about, and that is what's the value of the services that are being provided. So what some people may know or may not know about me is that in the last decade of my full-time work life, I was operating a Medicaid managed care organization. And as such, we were bringing into this whole concept, this value-based care. We brought into this a functional assessment score and scale, and we brought into this, these measurement-based care options and levels of care. And the whole idea here was to improve access, to improve efficiency. And I've got some age on me, and many times in the earlier days, I remember saying even myself, well, I don't know how long it's going to take to provide treatment enough to get this person to recovery. It may be years to come. And it's exactly the way I was trained in the 1970s, is that it is going to take a long time. And, we just can't do that anymore and not be accountable for doing something like a best practice that's going to deliver results earlier on. So you think about accessibility, the efficiency, the electronic record capacity that Andy mentioned a while ago. Focus in on episode of care needs. You'll see in those groups of services, and she had time measures in there. So we're talking about episodes of care, which is a part of that cultural shift. It is one of those barriers that we see by providers and by organizations, is that we've never thought about it that way. But most best practices are now grouped into time frames, and also they're costed out in that same kind of a way. So we need to understand these things. We need to make that happen. And then really talking again about the different kind of rates that we might see as well that might come again with an opportunity like a level of care. You didn't see any cost values there because they're so unique and customized to a particular state or an organization or a particular client population with a diagnosis and extra social determinants of health. But we've got states doing this. I've recently worked in the state of Ohio that have built these in the same process, where they're paying on a diagnosis or a set of diagnoses around a level of care. So just thinking about that, that's some of this kind of context that we need to understand this. Don't forget the value. I would often ask the providers, why should I choose you to buy this service from for my Medicaid members? And that very question just changes the whole outlook about this and drives this level of care opportunity. Next slide, and we'll talk about one more piece of the context here. This workforce shortage has to be placed into this context as well. So Annie was telling you a lot of information about how that particularly services we need to be moving people through the system. So the opposite of that is people getting stuck in the system and living in the system for long periods of time and not making progress. And the problem with that is that we have this combined with the workforce shortage, which again leads us to lead people to really need to be moving forward. So there needs to be a constant turn in the clients. In other words, people have to get better, and we have to know when they're going to get better. This is not only attractive to the workforce that we know and that we love and that all of us are embraced of, but it also is important to make sure that we also have the capacity to deal with the people. So I've just got some comments there about the workforce shortages. I think you all know that, but I think that's part of the context of moving people through levels of care. And the next slide. So these thoughts are innovative, I believe. And so I wanted to kind of take us to the step of, in the beginning, where did this all come from and how did this happen? So, and then what are the steps we need to take to make this work? So I've given you that context of value and measurements and results. Now, thinking about this, it all starts with the assessment and this evaluation of the identified need. And let's not forget strengths. Then treatment begins with this, with the evaluation and their ability to perform daily living skills and overall safety of themselves and others. So we're thinking about function and we're thinking about symptoms here. And I'll tell you, just thinking about a long time ago when I was trained, we spent way more time on the symptoms of the dysfunction than we ever did on the strengths or on their functional outputs. But we know that clients, and kind of going back to that poll again that you just took, clients understand more about their dysfunction and their function, what they want to be, than they do about symptoms. Sometimes they equate those, but it's important to not forget that clients really see function as something that they want to achieve. And when our treatment goals and plans are designed to bring them to a functional level, maybe it's back to a baseline, or maybe it's to go above a baseline. Either way, they can visibly see that it's reasonable, and they can understand that, they accept that. So this is about those measurable targets again to improve those functions. So that's how we got started with using these levels of care. And the next slide. So these guidelines, I like to try to define them for you again. You've seen some examples that Andy's provided so well. And these are really about driving these evidence-based behavioral treatment opportunities for people again, and trying to produce better results. So with these goals of resiliency and well-being, and what that means to the client, and you might ask them what that means as you're doing treatment planning with them. Since I've already disclosed that I worked as a payer for a long time, and what we use these level of care guidelines on is to drive more evidence-based practices into the picture. We would sit around and scratch our heads and think, can we only pay for evidence-based practices? Can we just stop buying anything that's not that? Well, and the reasonable side of me would say, okay, that's a great idea, but everybody's not ready for that. So we need to bring people up to getting them ready, and level of care guidelines is a way to do that, to promote those evidence-based practices. So this is that dynamic kind of transition organizationally that is going across all the levels to make sure people get the right service at the right time, at the right intensity and frequency, as Andy mentioned. But let me add this next category, at the right cost. And that's how we package up these level of care guidelines. And the next slide. Okay, so Andy said it enough, but I just want to mention again that let's not forget these transitions across levels. This has been one of the problems with what we haven't had in the past, is the ability to really categorize levels of care and transitions. And when I work with organizations around this, they often tell me this is one of the barriers. They haven't viewed this in that way. They see people staying in the same level of care for a long period of time. I want to tell you this is a very dynamic process, and it really goes along with the specificity that we have now of the diagnostic process. So we talked about ICD-10 a little bit and how that matches up to these levels of care and function, but let's add the ICD-10 process to it as well, with even greater levels of specificity. So I've got an example here, in the middle of the page here, that if you have somebody that begins with a current treatment for major depressive disorder that is recurrent, meaning that this has come and gone in the past, and there's evidence of that. And it's also severe at this time with psychotic features. As a person drops the psychotic features, they're responding to treatment, then we're gonna drop the diagnosis for that. We're gonna say now they have major depressive disorder, moderate, without psychotic features, maybe after 60 days of treatment using evidence-based practice. So you can see how that will work, and the reference point here is that when you change the diagnosis, you're now changing into the transition of care to some different kind of level. They don't need that anymore. They need to maintain that anymore. Maybe they've even gone from severe to moderate. So you see these transition criteria are put into a level of care to help us to make those transitions. It is needed to help give us the guidance for that. And the next slide. So a rationale, these are challenge questions I want you to think about, and then we're going to come up with a poll question in a little bit, one more before we close out today. Can you show effectiveness along meaningful outcomes? Again, you might not want to answer that question too quickly, or if you asked me that a number of years ago, I would have been embarrassed to answer that question in front of you because I didn't have a very positive answer to that. Is the client and consumer experience positive? Care when the client wants it and when they need it, not when it's convenient for us. Is the care efficient or cost effective? Some of these value questions, again, is all of the care coordinated among a team of providers to eliminate redundancies, create synergy, and improve care outcomes? Is there a partnership with the clients and consumers? We see this in all aspects of healthcare now, and particularly I'm seeing a lot of this in cancer treatment these days. Annie used an example of other medical services that we see that run parallel to what we do. This is a perfect example of this whole rationale about the levels of care needs to follow along with a partnership as well with consumers or clients. What is their responsibility? What is their accountability? And let's share with them, again, openly, these things that we know about them, and as a way to try to help them move along. And the next slide, please. So let's link this before we close out again to medical necessity and the golden thread of documentation. So I know you've already looked at some other medical necessity information, but we want to say particularly clearly that when it's not clear, cut, and dry, to these exceptions and all that Annie mentioned a while ago to some of these levels of care, it all needs to come down to being medically necessary. So nothing kind of exempts us from that. This is all integrated into the whole aspect through the Federal Register and through the Center for Medicaid and Medicare Services and through other health plans. And medical necessity still remains the driving force. And so when we see transitions or uniquenesses about a client, if they're medically necessary, you can make movements and transitions through these levels and processes. But that's important, and let's not forget, again, they're all sealed really down into the ICD-10 diagnoses that are the ones that are reported and claimed. So this is the data set that a payer sees. So I'm telling you a little bit again that payers will somewhat drive some of this for us, but it's always good for providers to get out ahead of payers. Knowing that I used to be one of those payers, I want to encourage you to always be ahead a little bit of the payer system and know and anticipate what they're going to be doing. Next slide. Okay, so again, these actual stays and services, again, are going to be person-centered. Again, this is where, again, medical necessity comes in line. And even these lengths of stay, again, they're going to vary per each individual, but all are going to be around the medical necessity drivers for this. And the next slide. And then let's talk about recovery. These interventions and the resources and all all the functions that you saw Annie describe to you in these boxes, of these packages of services. These are all about the improving the state of health about a person and their recovery, and then to maintain that, to develop a level of independence, if you will. And that's why we use these functional assessment scores to help to get someone to that area. And the next slide, I believe, is a doodle, the poll question. Nope, not yet there. So, so how these can be used again are that you can be required to use them by payers, or you can self-impose that on you. You can have a state waiver, for example, for Medicaid that requires a level of care use. Some states, a lot of states have that now. The state that I'm in is also like that. We also have the standardized kind of guidelines. This helps to reduce that variance. Very consistent, again, with the triple aim or the quadruple aim that we once knew, from SAMHSA and the Center for Medicaid and Medicare Services, again, about improvement in outcomes, cost effectiveness, again, and the experience of healthcare. And it could resolve these rate disputes that could be a part of maybe our past that we might anticipate for the future. Next slide. Yes. Now there's this poll question. So one more poll question. We'll allow about 60 seconds, and then we'll be back together again for this. So what is the percentage of evidence-based practices at your center? So consider that over the whole amount of services. What's your estimate for that? We have 4 options. Is it 25% or less, 26 to 50%, 51 to 75%, or is it above 75%? These are the services provided by your organization. Remembering as you're answering this, the driving push for value-based care or using levels of care is to increase that percentage over time. Jody, let's go ahead and close that now, and we'll see what the answers are here about this. So for the 0 to 25%, you'll see on your screen a 14% usage rate of this. That's and then for the second group, 25% of you responded that you're right there for evidence-based practices. This is really nice, a whopping 36%, the largest majority, feel like that 51 to 75% of their work is involving evidence-based practices now. And then above 75%, that highest level is a 25% grouping. So this is really a nice statement for us all. So, okay, so that's the end of this, and I think we'll just go to see if there's any questions about the presentation that we've had today. Let me look at the questions and answers. Jody, you know of anything or?
Yeah, David, I'll be happy to take one. One came in, great question. Does a DLE-20 assist the assessor with identifying applicable Z codes? It does, because what the DLE-20 does, when we think about a Z code, this is an individual that has symptoms, but they're not meeting the criteria yet of a specific disorder. What your DLE-20 does is it takes any and all symptoms, even if they don't have a disorder yet, to say, how are those symptoms impacting their life from both, again, a physical health perspective and a mental health perspective? So we place the DLE-20 in federally qualified health centers, the public health department in some states, in jails, in prisons, in schools, and not every individual in there is going to meet criteria for actual disorders. But do they have some symptoms that could be impacting their functioning? Absolutely. So your DLE-20 is not a diagnostic tool, not a risk tool. Instead, it takes any and all of that and says, let me see how they have been functioning in the last 30 days and what 20 quality of life indicators were impacted. Great question.
Yes, and I'm seeing also several about will the slides be available? Yes, they will be. I'll let, I think they'll be posted to the National Council website, I think, and they may be posted to ours as well. Jody might give us some guidance on that. Another question, and this, Annie, you might see this one, you might be able to help. What about inpatient services? Is there any evidence that the DLE-20 is effective in the inpatient setting?
Yes, it is. So here's what I'll say about the DLE-20 with inpatient. So when you do a DLE-20 and you're doing a snapshot of the last 30 days, sometimes our inpatient stays are so short that what people will do is they'll do a DLE-20 at the start of admission into inpatient to kind of, again, justify that level and show that severity, which our payer sources also want to see. But then sometimes they aren't doing it upon discharge. If they've only been there 3 or 4 days, the challenge with that is your DLE-20 looks at the most frequent patterns in a 30-day period. So it's not going to move that score and move that needle in 3 or 4 days. But the nice thing is then when we refer them, and it might be our own organization or another organization into other levels of care, the DLE-20 can follow them. So now we have one from admission at the hospital, but then 3 months later, when they're in our outpatient services, we can see a snapshot of how they're doing. So yes, we do use it with that. If somebody's there for a longer stay, we do sometimes see inpatient facilities do it at admission and discharge. We also use it with partial hospitalization, crisis stabilization. Do organizations that contract with MTM get access to the DLE-20, or is it a separate purchase? It is a module. It's a training module that you all purchase. Once you purchase it, you have a lifetime of access to the DLE-20. And the training that we actually do is a train the trainer model. So then you also have your own internal trainers for your organization so that you can sustain it with new programs, turnover as staff come and go.
Very good. And I know there's some more, but we have run out of time, and I know people are trying to be timely, and this is recorded, so maybe we should close down. But any other questions, you can write us. You see our email addresses right there. You can write us to ask those kind of questions, and we can provide the answers to you. So thank you for your attention. Thank you for the work. Andy, you want to close us out?
I would just say again, thank you so much for participating today. Really appreciate it. And we hope you all have a great rest of your week. And please, again, like David said, do not hesitate to reach out for any additional information that you'd like.
Yeah. Thank you all for attending today.
Thank you. Bye-bye.
Bye-bye now.